of Psychiatry at the Baylor College of
Conference
Medicine.
record has joined the conference.
Really one of our leading thinkers on the approaches to people living with borderline personality disorders. He's compassionate, he's smart, and if you see any of his articles, he's actually easy to read. He's one of the people, when I see an article written by him, I'm like, oh, phew, I'm going to be able to understand this, and this will help me be a better medical director for Nami. Some housekeeping things. We're going to have many people on the call today. Every beep you hear is a person coming on. There are many people on the call who won't talk. I am going to ask everybody to please hit *6, except the good doctor, to mute their calls. And this helps us with barking dogs, adventitious noise, people doing dishes, people sharing with family members what they're learning on the call. We have these all the time, and you can hit #6 when we get to the question and answer section of the call in about 20 minutes after John does his introduction. So that's helpful. These calls are recorded and can be found at www.nami.org/askthedoctor. And we're very fortunate today to have Dr. John Oldham, who is really one of the national gurus on borderline personality disorder. In typical Ken Duckworth fashion, I have double booked myself for this 1 hour. So my very capable colleague, Emily Kepler, also a graduate of the University of Michigan. This is something Emily and I share routinely, except when it comes to discussing college football problems. Emily will be running the question and answer component to our call. Thank you again for joining us today, and if you wouldn't mind taking it away for 15 to 20 minute overview, and then we'll do a question and answer section. Then at the end, we'll ask you to please give us your favorite resources, articles, books, guidelines, because one of the things that people always want is they want to learn more. Thank you again, and take it away.
Okay, thanks, Ken, very much. And hello, everybody. I'm happy to spend a few minutes talking about borderline personality disorder, which is an extremely important and extremely prevalent condition that can be quite severely disabling, and really both for patients and for families and loved ones. I'm going to just hit some of the high points, and then we can have time for questions and answers. First of all, the term borderline is one that some people have not understood. It originally was coined because the condition was thought to be kind of on the border of psychotic conditions. It was clarified as we've understood it better that that's not really the case. I was on the American Psychiatric Association work group for personality disorders for DSM-5, and a lot of people suggested that we change the term because people react kind of negatively to it. In the end, we decided that it would be better to leave it because what's important is to understand the illness rather than change the label. Actually, I say to people that it is still a very applicable term because it's on the border of major mood disorders and also impulse control disorders. And those are conditions that, in fact, characterize patients with borderline personality disorder. And those are spelled out in the defining criteria. In the current DSM-5, the criteria in the main section are the same as the ones in DSM-4, so those have not changed. And one is diagnosed with this condition if you have 5 or more out of 9 criteria. If we have time later, I could say a word about an alternative way we're thinking about personality disorders, which is in Section 3 of the DSM-5. We may or may not have time to go into that. But the main characteristics of this condition are emotion dysregulation and loss of impulse control and a lot of difficulties in interpersonal relationships. It's not just one type of person who would qualify for the diagnosis of borderline. There's a lot of heterogeneity, and it's a mix of symptoms that are fairly common, sometimes things like self-injurious behavior, and also traits which characterize this condition, which are things like feelings of emptiness and uncertainty about your identity and a sense of self. We tried to clarify that a little bit better with the new model. There's a lot of comorbidity is a term that's often used. That is, patients with borderline personality disorder often have other conditions as well, such as major depressive disorder, even bipolar disorder. There's often a substance use problem and sometimes a co-occurring anxiety disorder. One of the big concerns for people with borderline personality disorder is a high risk of suicidal thinking, and sometimes suicide attempts and actual suicide. And this is something that is a big concern and a risk factor. How do you, what causes, how do you get borderline personality disorder? I think it's important to understand that this is very easy to think about exactly like we think about other major mental illnesses and also even medical conditions. And it's called the stress vulnerability factor. There is a very significant degree of heritability. This condition can be, you can inherit the risk to develop borderline personality disorder just like you have a risk to develop depression or an anxiety condition or other things like alcoholism or medical conditions like diabetes. Borderline is at about the same level of risk as conditions like some forms of heart disease and high blood pressure. So it's a significant amount of heritable risk. The way to think about it is that we all have in our families things that run in the families, and that might be one of those conditions in medicine like depression, or like diabetes, but it can also be depression. It can also be borderline personality disorder. If you have that risk factor, it doesn't mean you're necessarily going to develop the condition, but if you hit a significant, major, stressful period in your life, that could activate that risk and lead to the development of this condition. Fairly often one sees problems that can occur developmentally in terms of early trauma, but that's not invariable and it's not essential for the diagnosis. We know a lot now about the neurobiology of this condition. It is something that we've learned a lot about, and here's one example that I think is an important one to really focus on. And most of us, one of the things that is what helps us make decisions, control our behavior, make choices, is a pretty strong neural connection, a nerve tract connection between the emotion center in the brain, which is deeper in the brain, and that's called the limbic system. And that's where the hippocampus is, where we store memory, and the amygdala, which is where the emotions get generated. And that's connected very strongly in most people with what's called the prefrontal cortex, the surface aspect of the front part of the brain. The brain imaging studies have shown that most of the time patients with borderline personality disorder have a reduced volume of some of those emotion center structures, and almost as a compensation, they tend to be hyperactive. In addition, there's a weakness in the connections between that emotion center and the cortex. And you can think of it this way. Think of the emotion center as kind of the engine for emotions. It's overreactive, so little things can stir up very strong emotions. But it's a double problem because the power and the way we turn down the heat in strong emotions is with this connection with the frontal cortex. And if that's not as strong as it needs to be, then it's a double problem because you have a very strong, excessive emotion and you don't have the brakes to turn it off. So that's important to understand, because sometimes when patients with this condition get highly emotional and sometimes even agitated and anxious, people can get angry, can take it personally, can feel like the person with the borderline condition should just calm down and not be so emotional. That's not something the borderline patient can easily do, and we know that there are neurological reasons for that. We're seeing other things in our science studies that are important. We have clear evidence now that there is a lot more what's called dysregulation of emotions, that emotions kind of can get pretty stirred up and pretty frequently very, very intense. In addition, there seem to be other factors that we're learning about. There is some alteration in internal pain regulation called the opioid system. There's also a growing body of evidence that there are some problems in other things, such as a neuropeptide model, which refers to oxytocin, and that's really called the trust hormone, and that develops really right at birth in the bonding process between the mother and infant. And if that's not at the normal level, there may be an interference with the ability to develop comfortable trust in the early period of development, and then that's seen later in life. Often patients with this kind of problem end up, because of this emotional instability and what's called impulsive aggression, it interferes with their ability to learn to trust people, and even interferes with the usual attachment process during development with parents, so that together this leads to a lot of instability in friendships, in romantic relationships, and that becomes a very big sort of continuous problem for patients with borderline personality disorder. So to kind of recap what I've just said, I know that's a lot. You can start, you imagine the way it starts is with these inherited risk factors that sort of set the stage for a lot of emotionality, a lot of impulsivity, and a lot of difficulty trusting other people. If there's been a significant stress or repeated experiences of stress that turns on this intense emotion and impulsivity, turns on the increased amount of mistrust, and then leads to very difficult interpersonal relationships. And when the interpersonal relationships then start to become stressful, the person with borderline personality disorder develops other symptoms such as suicidality, and then there's a compensatory effort. And one of the things that sometimes happens is that a patient with this condition will show some self-injury, and patients can cut themselves or burn themselves, which for most people would be painful. For persons with this condition, it actually turns off that intense emotion and finally brings some relief of this really distressing state. So it's a very difficult life to lead for somebody with this condition, and it's a difficult situation for family members and close friends, because there's a sort of roller coaster of emotions that pulls a lot of people into its orbit and becomes a real problem. We do know that there are studies that now show that treatment can be very effective and helpful for patients with borderline personality disorder. I had the good fortune to chair a work group of the American Psychiatric Association that developed a an evidence-based practice guideline for treatment of borderline personality disorder. And the evidence clearly shows that the treatment that is recommended for this condition is psychotherapy. And psychotherapy is the primary treatment. And sometimes medications can help with some of those intense symptoms and with some of that depression and emotionality. But it's not going to make a fundamental change that will be leading people to a better emotional and mental state. Psychotherapy can be very helpful. The original psychotherapy that was studied and demonstrated was the dialectic behavior therapy that Marcia Linehan and her group developed, and that's a very frequently seen type of therapy that is still quite strongly endorsed in the literature. But there are many other kinds of therapy as well, such as cognitive behavior therapy, mentalization-based therapy. Here at Baylor we have on our adjunct faculty Dr. Peter Fonagy, who's one of the pioneers who developed that treatment. But others called transference-focused therapy and schema-based therapy. There are a number of different kinds that can be quite helpful. There have been practice guidelines that actually say the same thing as the United States version that have been developed in England and in the Netherlands and in Germany and in Australia, and they all demonstrate that psychotherapy is the treatment that works. Let me just say a word about the nature of psychotherapy, because I think that's also very important, and then I'll open up to questions. One of the things that we do here at the Menninger Clinic is we have family workshops where we try to provide information to families when patients are hospitalized here. And we have quite a few and quite often patients with borderline personality disorder we take care of here in the hospital. And one of the things that I describe to them, we also do the regular kind of didactic workshops with the patients themselves, and I give a talk to them sort of lecture style. But there's a difference between something that's called short-term retention that we need to kind of live our lives day to day. A good example of it is if you're cramming for an exam in college or in school, you can learn a lot, do pretty well on the exam, but you don't remember that after a while. And people always kind of smile when they think about that because they remember doing all-nighters, but then all of it's gone. That's a very different thing from long-term learning and memory. And long-term learning and memory changes the brain. We've got a lot of data that demonstrate that, which is pretty amazing because we used to think psychotherapy wouldn't have an impact or an influence on the actual structure of the brain. But it does. But not that short-term 2 or 3 session version, because that really would be like cramming for an exam, and that's not going to stick. Longer-term treatment, you can think of like learning a second language. If you work at it and practice and stick with it over a long enough period of time, you will then be learning a new language. In this case, it's a language of behavior and understanding yourself and people. And it's something that then changes the brain and leads to improvement over time. Studies have shown that over time, patients with borderline personality disorder in fact get better, and that's the good news, because we used to even define it as something that is stable and persistent over time. But we know now that, in fact, a lot of the criteria in the definition of the disorder kind of decrease over time, and patients do get better. And that's true because they can engage in a lot of different kinds of treatment. And also the aging process itself may bring a capacity to shed some of these some of this emotional turbulence as people mature and as the years go by. So we're in a point right now where it's better news and better understanding of this condition. So to recap what I've said, it is a condition that you can have an inherited risk for. It's a condition that is usually precipitated by extensive stress. It's one that then leads to difficulty controlling your emotions and having a pretty thin skin and being hyper emotional and reactive in a way that you can't really turn off easily. That becomes a very secondary problem because of that emotionality that is so easy to activate. We've also understood that therapy works, and that the main thing that I say to people, and this will be the last thing I'll say at this point, and we'll see what your questions are. I think there are three major important factors to help patients with borderline therapy get better, borderline personality disorder get better. One is psychotherapy. Now, that's a lot harder than it sounds, because it's got to be something that you have somebody available to go and see. So the three things that I would say are: one, therapy and a good, solid therapeutic alliance with a therapist where you feel it's a good fit. Number two is money. Somebody's got to pay for it. Insurance companies usually do not cover therapy for borderline personality disorder. In my book, that's a travesty. That should not be the case, but that's almost always the case. But you need a good therapeutic relationship. Number two, you need to be able to pay for it. And number three, you need to stick with it over a long enough time for it to make a difference. Patients with this condition often get mistrustful, they get angry, they feel that people are not understanding them, and they tell people to go away. They abandon people, and it's also true in therapy, so that you see sometimes that the very nature of the problem surfaces, and then patients can fire their therapist and leave. Now, not every therapist is able to do the best job, and sometimes it is important to make a change. But if you can hang in there and find a good therapist to help you and stick with it long enough, then the picture gets very much brighter and people can get better. So let me stop there. And Emily, I'm not sure how we do it in terms of opening up for questions.
Sure. So thank you very much for providing all that information. I feel like I learned a lot, so I'm sure everyone else did too. At this point, we're going to open up the discussion for questions. You can ask a question by pressing #6 on your phone to unmute your lines, but we do ask that if you're not speaking, you please keep your phones muted.
I do have a question.
Okay.
Sure, go ahead.
I'm a clinical psychologist with VA. I've been working with a high-functioning professional who one of his diagnoses has been borderline, and I'm the one that has diagnosed that. I've kept it as a rule out because of the questions that come up with that diagnosis. However, what I wanted to say is I've been working with him for over a year, 2 suicidal attempts in that time. And I was fascinated by what you said, because I've actually felt like I'm watching his brain change. He's formed a therapeutic relationship. He's been consistent in attending. It was 2 times a week for a while, then 1 time a week, and now we're to every other week. And it seems like he's just changed. And I guess my question is, I'm a little afraid to trust that change. I'm a little concerned about, does this also move backwards, and how long does a therapeutic relationship need to stay in place to maintain those gains and to know that it's a, quote, permanent change? Thank you.
No, that's a very good question and a nice example. Of course, there's no absolute black and white answer to that, but the studies that have followed how patients do with this condition over time, and there are two different groups. The collaborative longitudinal study that was started by John Gunderson, and that's been going for about 15 years, and the other is the McLean study by Mary Zanarini, which has been going for over 16 years. And in both of those cases, what they demonstrated was that there is not a very high rate of exacerbation of the condition once people are getting better, so that a remarkable percentage of these patients do stay in a better place once they get there. Now, that doesn't mean that's always. Sometimes new stress can come along and can stir up some of the same patterns, but usually it's not for as long as it would have been earlier on. What we do see, though, is that over time, it's less rapid for people to be able to get to a good level of social and interpersonal and occupational functioning. So they can get to a much less symptomatic state, but it's harder for the patients to kind of re-enter the workforce and resume a kind of comfort zone socially and interpersonally. I think what patients learn to do is to identify what the kinds of situations are that might trigger their emotionality, and then try to minimize those situations or avoid them. So those are some of the guidance, and I think it's often useful if you've gotten to a place where someone is doing better, like your patient, to maintain your door open, maybe cut down to once a month, but a check-in over time, even for a few years, can be a very helpful stabilizing influence.
Thank you very much.
You're welcome.
Hi, my name is Rick.
Hi.
Hi, thank you. I have a 33-year-old daughter that lives with me, and there have been a number of diagnoses, one of which is borderline, another is schizoaffective, major depressive, dissociative identity, some gender issues. And she's been under a lot of stress. About 8 months ago, her mother passed away, my first wife. I'm wondering if you could maybe discuss some of the differences between borderline and what has been called complex post-traumatic stress, even though I know that's not in the DSM.
Right.
And also the issue of if, like in this particular case, my daughter, should she truly be borderline, I have read when they start to get better, that implies loss of the support system, and this implies or brings up the chronic suicidal ideation, self-harm. How do we deal with that?
Okay, that's a good question, and it sounds like you've been dealing with someone trying to help your daughter who's herself really struggling. There are overlapping aspects of borderline personality disorder and complex PTSD, but they're not the same conditions. Just like there's some overlap between borderline and what's called bipolar 2 disorder, so that some of the emotionality can characterize both and reactivity can characterize both. But the post-traumatic stress disorder includes things that were typical of just regular PTSD, such as the kind of startle response, the kind of nightmares that are typical, that are related to the trauma itself. And that's part, at least, of a complex PTSD picture. So I think we had a discussion in the DSM-5 group with the PTSD group about this very issue, and there was a pretty good consensus that there are some overlapping symptoms, but they're basically not identical. And if you do have some of the typical mainstream PTSD conditions, that would tilt it a little bit in that direction. Regarding the other part of your question, in terms of loss of support, I think that's a very important thing to be alert to. You want to sort of plan ahead and make sure that it's almost a little bit related to the question just asked before, which is when is it possible to wean patients off of therapy? When is it appropriate to sort of reduce and back away from a kind of network of support. I think it's important not to do that too quickly, and to make sure that there is that there are set at least of basic support opportunities for the patient that remain there for quite some time. You may cut down the frequency, like I was displaying to the other person, but you want to maintain clarity that it's great that you're doing better, but stresses never go away. And so here's where you can go, here's where you can call if something really gets to you.
Okay, thank you.
Sure.
I have a question.
Yeah, hi.
Hi. I was wondering if there have been any studies done about the success of therapy if you catch it earlier as opposed to if you're diagnosed later in life. Does it make a difference? Is there a better success rate if it's diagnosed, say, at 19 instead of 35?
I don't know of specific studies that have looked at that question. It's an interesting one, and there may be some. I just am not aware of them myself. I guess my answer would be the sooner the better.
Okay.
Because between 19 and 35, there's a lot of suffering that's going to go on. So one thing I would say is that in the former diagnostic manual, there was a kind of stipulation in there that made it sound like that most of the time you don't diagnose borderline personality disorder until someone is 18 or older. And actually, that wasn't an absolute rule because there are ways to do that. But that's no longer in the diagnostic manual. That's been removed because we know that you sometimes see this emerging in mid-adolescence, or certainly most of the picture can occur then. In fact, more commonly, it does have its onset in adolescence or early adulthood in the early 20s. So I think once it's clear that this is what someone is struggling with, then the earlier you can get into the treatment that helps, the better. And that's, I think, the main thing I would emphasize. I think that over time you sort of eventually get to a point where somebody may be so entrenched with expectations that everything is going to fail and nothing's going to work out and nobody's going to stick around in terms of friends, that the pathology can get reinforced. So it may be a little harder because there's been a long track record of repeated experiences that make it harder to be optimistic. So though I don't know studies that have been done in that regard, I would think that it would be not unlikely to find it difficult to kind of get to a better place if you've had a long stretch, because usually that's including going to see lots of doctors. One of the big problems is that this condition does not get adequately identified and diagnosed. So it will be called bipolar disorder, it will be called an anxiety condition, and patients will see their family docs, or they'll see their primary care docs, and they will often be giving medications. What we call polypharmacy is not at all uncommon, where patients are on several different medications. Those may even complicate things because they'll have side effects of their own. So there could be a lot of time go by when it's not that patients are not seeing anybody trying to get help, but they're not getting the right kind of help.
Thank you so much.
Dr. Oldham?
Yes.
I have a question. I would appreciate if you could speak a little more about the differentiation between borderline and bipolar, and especially as it relates to the mood disorder feature of it and the impulsivity. And also, if you could speak a little bit to the reluctance of the sort of traditional reluctance of mental health providers to work with folks who have borderline symptoms or borderline disorder.
Okay, sure. Regarding the mood and affective disorder, I think the first of all, it's not that difficult to differentiate borderline from what's called bipolar 1 disorder, which is the bipolar condition that involves significant major depressive episodes and then significant major manic episodes, because the manic episodes are defined as fairly extensive over a described period of time, sort of not uneven the way borderline patients show all kinds of reactive emotionality, but there's a kind of a manic grandiosity, euphoria, completely opposite state from the severe depression. So that pattern is pretty clear, and it's more what's called bipolar 2, which is characterized mostly by depressive episodes, along with what's called some hypomanic, which means not quite manic, not extensive, not prolonged, the way I just described in bipolar 1. But even then, the kind of hypomanic state is not fluctuating on and off and on and off the way you see a kind of dysregulated pattern in borderline. So most of the time it's the sort of pattern of the mood changes that differentiates the bipolar from borderline itself. Now, I will add that some patients have co-occurring conditions and meet the criteria for borderline itself, plus bipolar disorder. That can happen. But the main way, at least clinicians try to sort that out, is just by going down the diagnostic criteria. And often it's the profile of the mood state that differentiates the two. Regarding your other question, it's a huge problem, just a huge problem. Medical providers in psychiatry itself, in psychology, and mainstream family practice, hospital personnel often react quite negatively to borderline patients. They can see them as pariahs, as people they dread, and often I think the reason for that is that they do not understand the illness. It's really interesting when you think about behavior. If you had a patient in the emergency room who was out of control because the patient was having an epileptic seizure, nobody would get mad at the patient. They understand what's happening, and everyone rallies around and tries to help. Maybe that's an extreme example, but it's an example of behavior that people understand. When patients with borderline are emotional, I tried to explain earlier, they are out of control. They can't turn it off. But people who work with these patients don't understand that. And one big difference is that sometimes it's the underlying core mistrust and anger and feeling like there's been a lifetime of not being understood that the patients express when they're emotionally aroused. And they then will not cooperate with other people. They will not trust them. They will argue with them. And this is part of the emotional motor that's turned on. But it can be directed very clearly at the very people who are trying to help. And if they don't understand that this is a part of the illness itself, then they sometimes take it personally. They say, why don't you listen to me? Because my job is to be here to try to help you, and all you're doing is yelling at me. So there can be over and over again experiences like this, and then the person in the health care role grows to feel like all borderlines are going to be like this, and they develop an attitude. I think the best way to help people, and try to do it every time I get the chance, is help people understand some of the things I was talking about earlier, that this is a heritable condition. It's a brain disorder. If you have a stroke, you have a brain disorder. If you have borderline personality disorder, you have a brain disorder. If you have depression, you have a brain disorder. There are things that you have inherited risk for and that you don't have control over. And people need to understand that the behavior is illness-driven, not just a function of somebody being obnoxious, which is the way people can sometimes read it.
Thank you.
Yeah.
Hello, doctor?
Hello.
Hello. Can you hear me?
I can.
Oh, wonderful. My sister is age 64, and in consulting with a therapist colleague of mine and a psychiatrist, it was determined that she has borderline personality disorder along with OCD, paranoia, and at least 2 psychotic episodes that I know of. The psychiatrist has told me that she will either end up in hospital or in jail. I can see her deteriorating. Fortunately, she lives 2 states away, and I can pretty much, my husband and I can insulate ourselves from this. She has absolutely nobody in her life. I am her only relative. And her boyfriend, who I have sent all kind of literature to on this condition, just seems to be sitting on his hands and ignoring it for his own social reasons. So my bottom line question is, how do I get someone like this into therapy? I hear from the psychotherapist that this is a very difficult condition to get someone to seek help.
You know, I wish I had a good answer for you, but it is a common challenge. And patients can sometimes be so convinced that there is no help for them, and they sometimes can also be convinced that they're not the ones with the problem. It's the fact that other people are unreasonable and they don't understand them, and they don't need treatment, but if anybody does, the other person does. That's not at all uncommon.
Right, and the sad thing is that she is 3rd generation to have this. In my mother, it was diagnosed as nervous breakdown, for which she was hospitalized, and she died of dementia. And I just can't tell her, this is in her genome, and now it's in her phenome, and you will die the same lonely death as our mother had. She just seems impervious to the literature. She doesn't trust doctors. Her boyfriend trusts doctors even less. And we could, of course, cannot stage an intervention because, because of the distance and because my husband wants nothing to do with her. I know this has splintered the family, and she is finally meeting next month my grandson, who's almost two years old. And I just I'm happy she's finally getting in touch with the family again. But I'm also a bit leery with the psychosis around the relatives. And she is two-faced, and she can get along fine with people. She seems very shy, lacks any confidence at all. And
well, what you're describing is a huge burden. It's been clearly a burden for you and your husband and for her. And it sounds like it's also complicated because she's got borderline, but also other things, so that the paranoia you described may make it even harder for her to trust people and be willing to go and get help.
Now, as as far as the type of therapy goes, I have dealt with the cognitive behaviors for a sleep disorder, and I was very pleased. And my thinking is, should she go with a cognitive behaviorist, and then if pharmacological intervention is needed, then would he refer her to a psychiatrist? Would that be the best route?
I would think so. What I would say is that she should go to see somebody for therapy, and it's cognitive behavior or other kind of therapy, because you want her to go to see anybody she's willing to go and see. Mm-hmm. So if that's one she's willing to try, that'd be great. If she'd rather try some other kind of therapy, that would be worth it, because you want to get her in the room with somebody and then to stay working with somebody. And then they'll always connect with a psychiatrist if medications look like they might be helpful.
I see. But how do you screen for someone that would know and not shun borderline personality disorder, as you kind of spoke of?
You might just look for other resources. There's an organization which I would recommend, the NEABPD, the National Education Alliance for Borderline Personality Disorder. And you just Google that, and they have a website. And they have networks all over the country, also run family-to-family workshops to help families deal with patients with borderline.
Correct.
And
Correct.
So that's just another...
Let her talk. For Pete's sake, shut up.
That's just another resource, and they usually through their network will know of people who understand the disorder and would potentially be available, and can make some recommendations.
Right, and along that line, I am a member of Nami, and they do not have many resources on BBT.
Well, yeah, Nami is very, very interested in borderline, and has also, I think, got a lot of connections that would be very helpful as well. It depends on the part of the country, because sometimes some locations just don't have people who are trained in DBT or other specialized kind of treatment. But I think whatever the therapist practices who's available, as long as they have a basic understanding of borderline, that's the main thing, is just to get the connection made.
Doctor, I think it's, can I get in here?
Yeah, hello.
It's Mike Weaver, dashboard. But I just think it's important to, no matter whether it's borderline personality disorder, whether it's schizophrenia or bipolar disorder, that be an element of hope that remains, and some days it looks very hopeless. I'm sure my friends have thought I was hopeless many times in my life, and it's hard to maintain that hope. So I think the importance of hope has to be optimal in the treatment of people with borderline personality disorder. The aspect that recovery is possible, that cognitive therapy and other methods can work, and I also think that peer support, people who are trained in peer support, who know how to keep good boundaries, has been proven to be very effective.
I thank you for that excellent point, because I totally agree, and I think it's so important to get to a place where you sort of reactivate a sense of hope, because it can be very discouraging, and over time people do get into a pretty hopeless corner. And as I tried to say earlier, I think the evidence over time that we now have shows a pretty good optimistic picture that there is hope and that people do get better over time. One of the studies showed that 85% of the people with very clear borderline personality disorder who, when they entered the study, after about 10 years, were no longer even close to meeting the diagnosis. So people can get better. Those are hard, long 10 years. Some people get better sooner than that. But there is light at the end of the tunnel, and people need to hold on to that. And I really think you're right about that.
Can I ask a question?
Yes.
Can you hear me?
I can.
Okay. I have a 17-year-old daughter who is adopted.
Mm-hmm.
And I wonder if she keeps thinking if she would meet her birth mother that, she would feel this emptiness would go away. And, you're talking about the mistrust. I don't know if there's any correlation between being adopted. The other thing that our daughter does a lot, she's run away and she's not home right now. The police are searching for her as we speak. She's very promiscuous. Is there something about promiscuity and borderline personality?
Promiscuity is one version of a whole array of behaviors that are part of what we call a kind of self-injurious behavior or an impulsive behavior. So that's not uncommon, and sometimes you see that pattern very much, along with other kinds of behavior that can be self-injurious, such as using drugs or substances, alcohol, and other kinds of self-injury.
Okay.
So it does sound.
So you think of it really as more not sexual at all; it's just more injurious. She does cut, but
okay, yeah, I would see that as part of the pattern of behavior, and it's a little more complicated because it's also a kind of desperate way to be able to have people to relate to.
Right.
And it usually doesn't work if it's just a series of encounters, but it's underneath it is an attempt to be able to connect with other people. Regarding the adoption question, I don't think that there's much information about that in general because the only way it would tie in is that we do know that this is a condition that does, one, have heritable risk, and number two, then makes the person more susceptible to stress. And I don't know the history of your daughter, but it's often stressful when there is an adoption, or can be.
She was adopted at day one. I don't know, but she was. Maybe the birth mom says that her boyfriend was schizophrenic. So our psychiatrist feels pretty confident that she's not schizophrenic, that she's borderline personality. But maybe just the stress of the birth mom not wanting to keep the baby, the stress the birth mom was undergoing while she was pregnant. Could that be the stress, do you think?
Those could contribute, and certainly learning about this later as she's been growing up, it could all be part of it, and she may have some genetic predisposition to this emotion dysregulation. You don't always have major trauma, but if there's enough of a risk, it can show up.
Okay, we really can't think of any major trauma, but okay, thank you very much.
Sure.
Dr. Oldham, can I ask a question? Quick one?
Yes, please.
Thank you. I'm wondering if you could just address, from what I understand, another component of the illness is cognitive distortion. And I'm wondering if you might address that in terms of how the therapy can address that, or how that can outplay, because, we hear a lot that borderlines can make up stories and that kind of thing. And if you don't mind, I just want to make a plug for TARA in New York, TARA. They're an excellent group for supporting people who are family members of borderline people.
Yes, thank you for mentioning TARA. I just got off the phone from a call with Valerie Poor about an hour ago.
She's a big
who is head of TARA, and I'm actually on the board for TARA, and I should have mentioned that as well. It's another very good organization that helps people. Your question is a good one in terms of cognitive distortion. What happens is when there's a stressful situation and the strong emotions are kind of turned on in these patients, there can be such a level of agitation and then such a level of mistrust that patients with this condition then misread other people. They read sort of harmful intentions into other people's pretty neutral behavior. In fact, there have been studies about that show that if patients with borderline are shown pictures of faces of people that other people would just see as totally neutral. They will see hostility and anger and critical attitudes in those pictures. So they're kind of predisposed to mistrust people and to misinterpret other people's behavior. If another person is preoccupied by something entirely unrelated to a borderline patient, but doesn't seem to be paying attention to them, they will sort of sometimes blow up and interpret it very personally. That can then lead to even transient episodes of being almost paranoid, or other kinds of transient episodes of what's called dissociation, where they just kind of tune out and don't seem to be paying attention to what's around them. Those don't last that long, but that's a way you can see some of these cognitively distorted thinking patterns. So it's wrapped up with a kind of propensity to be on the lookout for what they expect to happen, which is to be criticized, mistreated, misunderstood, and not popular, not sought out, not liked by other people.
And this is Emily. It is noon, so we are going to wrap it up. I'm going to ask Dr. Oldham if you could please give us some papers or books that you think might be helpful for our NAMI members to read about borderline personality disorder.
Well, there's a new book that's actually for people who carry out treatment on borderline personality disorder by John Gunderson, who's at Harvard and McLean, and is someone with a lot of experience working with patients and families with borderline. I think it's just called Borderline Personality Disorder, but it was just published within the last year. It's by American Psychiatric Publishing is the publisher. It's a paperback, and even though it's written for clinicians, I think people could really get a good sense of what working with borderline patients is like. There are a number of sort of popular books that people have written that can be very helpful to some people. There's one called Walking on Eggshells, and there also just a pitch for a book that I wrote with a colleague some time ago, but it's still in print, and it's called The New Personality Self-Portrait. And it's a description of personality styles and types, along with a self-assessment test that you can take that then talks about different types. And there's a chapter in there that talks about we call it the mercurial type of person who's predisposed in the direction of borderline, and we talk a lot about borderline itself. And so that's just a general big picture of personality itself and the extremes of personality. I sometimes say it's like blood pressure. You got to have a personality like you've got to have blood pressure, but too much of it can become a bad thing.
Great. Thank you very much. And at this point, I'd really like it if everyone could take themselves off mute by pressing #6 and sing out a thank you to Dr. Oldham for giving us his time today.
Thank you so much.
Thank you very much.
Thank you very much. Thank you, Doctor.
Thank you.
Thank you all. Thanks, Emily.